Well, good afternoon, everybody. Looking at the RSVP list, I can see that many, if not most of you, are returnees. So this is the third in our series of answering the call. And for those of you who have been on this before, you've been seeing my hair grow. By the time we get to the next one, I'll probably be in a ponytail if I haven't found my way to a barber. Anyway, you do not need a video. You don't need a microphone for this event. On the lower part of your screen, you'll see something called Q&A. And at any time during the event, you can register a question, and you have the option of opting to ask it anonymously if you wish. We have about 20 minutes at the end of the speaking part, and we'll try to get through as many of those questions as possible. I'd like to thank the panelists who are joining us today. You'll be hearing from O'Neill Britton, who is our Chief Medical Officer. You'll be hearing from Dr. Zach Wallace, who is in our division of Immunology, Rheumatology, and Allergy. Dr. Wallace's primary interest is in the study of inflammatory disease. And as you probably know, one of the things that we've learned about COVID-19 is this remarkable inflammatory response, which leads in large part to the severity of the disease that we're seeing. You'll also be hearing from Dr. David Ryan, who is Chief of our Division of Hematology, Oncology, and Clinical Director of the Mass General Cancer Center. And finally, you'll be hearing from Debra Burke, who is our Senior Vice President for Patient Care, is Chief Nurse at the MGH, and leads the best nurses on the planet. And so I'll now turn things over to Dr. Britton.
Well, good evening, everyone, and thank you, Brett. I hope everyone is in good health and spending, whatever time you can with your families and friends and catching up. My job tonight is to just give you a brief overview of what's going on in the hospital, and I'll do that by describing sort of our current census and where things are in terms of our what we call our COVID-19 patients and our non-COVID patients. I'll also give you a quick update on what's going on with some of our workers here, our employees, and how they're sort of fitting into the big puzzle. And I'll also sort of quickly go through what's going on in the city of Boston, sort of what's going on around the state, and maybe even touch a little bit on how we're doing nationally in terms of COVID. So I'll start off by saying that, we're still in the middle of our pandemic. We're probably what we would describe as our slow descent. I think it's clear to everyone that our peak in terms of what we expected to see has passed. But now we have to sort of navigate the downside of that peak. And unlike what happened when we were headed up, which was a sharp rise in cases, the number of cases currently is trickling down. I'd probably describe that on average, we have about 11 less COVID patients in the hospital compared to when we were at our peak. And our total number of COVID patients today is 193, with about 85 of those patients in our ICUs. And about 80 of them requiring ventilators. We're still doing a lot of, we have deferred a lot of care in preparation for potentially having a major surge when this all started. And we have deferred that care, but today we see many of our patients returning, some because we can no longer defer their care, and some because of urgent needs. And so while we have almost, as I mentioned, 196 COVID positive patients, we have about 500 regular patients who are also here and who we're caring for. And so our capabilities to care for everyone is very important, and something that I just want to impress upon people, that there is no need to sort of, defer care if you're not feeling well, or if you feel like there's something that needs to be looked at. We certainly can take care of you. The next thing I'd mention is that overall in the state of Massachusetts, I think the latest governor's numbers today shows that we have approached 80,000 positive cases of COVID. And today we had a report of 1,000 new cases positive, just over 1,000, and about 170 deaths. That was a little bit more than has reported recently, and that was largely due to some clerical calculations on the state's part, because yesterday they reported an abnormally low number of deaths. I think they reported 33. So over the next few days, we expect that to settle out. Prior to this little bump, we were averaging about 130 deaths per day across the state. So it's still important to keep that in mind. And nationally, as many of you know, we still are rapidly increasing, unfortunately, with the different approaches to the COVID crisis by different states. But overall, we have about 1.4 million positive COVID cases nationally. I'd just like to mention that, this impacts everyone. It impacts families, it impacts, our loved ones, but it also impacts our employees. And so we have about just over 500 positive employees here at Mass General. We report this pretty much every day across all our employees. But even the trend amongst that has been steadily decreasing. And I'm happy to report that in the last 24 hours, we only had one person test positive. This sort of reflects, in my view, the slowing rate across the state, but it's also probably more reflective of the care and the caution which with our employees are sort of moving through our state and trying to make sure that they avoid coming into people who are infected or potentially infected. And so I just close by saying that, even though the burden of caring for these patients has been heavy, we continue to take care of all patients. I think we've had a tremendous, you'll hear more about from Debbie, Burke, and others around the tremendous work that our staff has done. And I think that, as we go down on the downside of the slope, I think people are starting to feel a little bit optimistic that all the social distancing and public policy measures that were put in place we're indeed seeing the impact of that. And we were clearly able to avoid some of the situations that you read about in New York and in other places such as Italy and Spain and other places around the world. So with that, I will hand the baton off to Dr. Zachary Wallace, who will tell you about his experience of caring for COVID patients.
Thanks very much, Dr. Britton. I'm happy to share our experience managing patients with COVID recently, and also our general experience managing patients with autoimmune diseases during the COVID pandemic. I'm actually on an inpatient team now where we're taking care of COVID patients. And I just want to start by acknowledging the incredible work that's being done by everyone in the hospital right now, especially the nurses, ICU staff, environmental services, and everyone else sort of on the front line. It's really been a privilege to be a part of this team. And I have to admit, it's been a challenging few days since I've been on service. And I would say it's been hard. This isn't my usual role. And I was telling a colleague today that sometimes I feel like a med student again, because in many ways, this is like a disease. This is a disease that we really just have never seen anything like it before. And I don't think we can go to work like we often do and know what to expect. There just continue to be so many unknowns, but it's really incredible to think of how much progress has already been made. And a lot of that, I think, has been done at MGH in a short time to really understand this infection. And I'm constantly learning on the fly just from my patients and colleagues. For many patients in the hospital, this has been devastating, not only because of the toll it takes on their body, but because their families can't visit. And I think one of the really heartening things to see is the way that everyone's come together to give patients an opportunity to sort of FaceTime or Zoom with their families. And it's reminded us, I think, how important families are for patients who are admitted to the hospital. We're privileged to have great diagnostics, treatments, and amazing nurses, but family is so important to helping us take great care of patients. So I think overall, being on the COVID service for just a few days has taught me that there have been some great successes, and I think there's a lot of reason to be really hopeful. And as Dr. Britton was saying, the numbers are looking better, which is really great. I think there'll be more challenges ahead, but a lot of great progress. And I think we're constantly reminded how much we still need to learn about this disease. My usual job actually entails being a rheumatologist and a researcher. And in those roles, I I sort of treat and study outcomes of systemic inflammatory autoimmune diseases, many of which are rare, some of which you may not have heard before, things like vasculitis, lupus, and rheumatoid arthritis. And when I'm not doing research, I'm typically seeing patients with these sorts of diseases in my clinic. And I really can't tell you how much I miss that like day to day of doing research and seeing patients with my amazing colleagues. But, you know, from a clinical perspective, COVID has really introduced a lot of challenges to our usual care in rheumatology, but I think we've really met them head on really well. As many of you are probably aware, our patients with many of these diseases have altered immunity. It may be because of the underlying disease, but oftentimes because of the treatment. And I still remember at one of our last in-person faculty meetings, a member of the ID division was giving us sort of an update on COVID. And I think we were all sort of struck by the fact that things weren't going to be the same again for a while, and things were going to change dramatically, and they did. You know, because of the vulnerability of our patient population, we quickly had to deal with shifting care from clinic to virtual visits by phone and video. And I think this is interestingly really challenged us to think of new ways to do physical exams virtually, to understand, for instance, how active an arthritis might be. And it's forced us to reconsider the frequency with which we do certain tests. And these are tests like labs and imaging that we've oftentimes leaned on to give us a sense of how well a medicine is working or whether a patient's body is tolerating it. And these have been stresses, I think, for us as providers. But I think patients have been incredibly grateful. I can't tell you how many times they've just thanked me for giving them a call or doing a virtual visit and being able to continue to get regular follow-up without, you know, taking a risk of necessarily coming in if it weren't entirely necessary. And it's been fun to connect with my patients and see, you know, their normal setting and where they live on video. And I know many people are talking about how we practice medicine in the face of this pandemic, and there will be challenges ahead. But I think it's also interesting to think about what we can learn from this natural experiment has made us do as providers. It's taught us a lot, I think, about how we might be able to provide care more efficiently in the future and virtually, even when we get back to business as usual. We provide such specialized care in many ways for our patients, and to be able to offer that to patients who may not be able to easily travel to Boston would be a really great thing to offer folks in the future. And for those for whom like an in-person visit may not be entirely great, I know they'd be really grateful to have a virtual visit and spare themselves traffic in Boston once in a while. I think, you know, we've learned an incredible amount about COVID. And for patients, though, in the beginning, I think for our patients, the pandemic really introduced a tremendous amount of uncertainty about how to manage their disease, how to quarantine themselves, and what to do with their medications. As I mentioned, many of our patients are on immunosuppressives, which we were concerned would increase the risk, not only for the infection, but also for complications. And we still don't have a clear sense of the risk our patient population faces in the context of COVID, and we were very worried in the beginning. While, you know, many of our patients are on treatments that can suppress their immune system, and that was concerning, you know, we were particularly worried because many of our patients have diseases that affect their lungs and kidneys and other organs, and we were concerned that that could put them at risk for worse outcomes for COVID. And so with these concerns, we were really worried, though, what would also happen if we stopped their medicines. And so a flare of a rheumatic disease could be life-threatening and require prednisone. And we as a community felt like the risk of stopping some of their medicines was too great. So we've had all of our patients actually continue their medicines. And as we learned more about COVID, I think that was probably the right decision. It's interesting to think that the management of patients' rheumatic diseases has actually gotten pretty interesting in the context of COVID. There are many clinical trials now, many at MGH, evaluating the efficacy of medicines that we use each day to treat rheumatic diseases as therapies for COVID. And this is because COVID follows a rather interesting course. In the beginning, patients feel what might be sort of like a flu-like illness. They might have some fevers, cough, achiness, some GI symptoms, and others. But for some patients, and we don't really understand why this is true for some but not others, a week or so into their course, they develop a more severe inflammatory response. And this is really still poorly understood, but really fascinating because it resembles some conditions that we manage as rheumatologists. they develop more difficulty breathing, worse fevers, more significant symptoms elsewhere. And the degree of inflammation when you check their labs is astounding, and is likely responsible for much of the severe morbidity that we see in patients with COVID infections, including the respiratory failure, clotting, the neurologic insult, and other organ failure. In many patients, in fact, we see some features in the skin, for instance, that resemble some of the manifestations of rheumatic diseases. It is this inflammatory response that has sparked the interest in studying rheumatic disease medications for the treatment of COVID. And it may turn out that patients with rheumatic diseases on these medicines may actually fare better in the face of COVID. But we still need a lot more data to understand that. And as you know, at MGH, we don't settle for a lack of data. And as a researcher, I set out with a lot of my colleagues from around the world to establish this global alliance that would collect data from rheumatologists around the world about their patients who were infected by COVID. And it's really been incredible to be a part of the effort leading this global collaboration. And we've already learned a tremendous amount. We clarified for the world that patients with lupus on Plaquenil do get COVID. We found that patients on steroids may be at higher risk. And we found that some patients or some medications actually may in fact be protective, like we hypothesized. And now we're trying to do similar things at partners, leveraging a lot of the amazing data that we have at MGH and some of the other institutions. So moving forward, I think our community has many questions that we need more data to answer. But I think we're all really very hopeful and optimistic that we're just going to see things continue to improve and hopefully learn a lot more about how to care for COVID and our patients with rheumatic diseases in this context. So thanks very much. I'm going to pass it on to Dr. Ryan now. So thank you.
Hi, everybody. Thanks for joining us. And I'm Dave Ryan from the Cancer Center. So I want to talk to you tonight about how the Cancer Center contributed to the COVID crisis at Mass General, how the Cancer Center is working right now in the midst of this COVID crisis. And then finally, I want to talk to you about how cancer care and the Cancer Center has probably changed in many ways for the good going forward because of this crisis. So first, how did we contribute? So it probably comes as no surprise that many cancer patients are sick. And so cancer nurses and cancer doctors are used to taking care of some of the sickest patients in the hospital. Now, we're not ICU doctors, but we do care for folks who have bone marrow transplants, have autoimmune issues related to the therapies that we give, and sometimes they can get quite sick. And so to those who've been given a lot, they are expected to give a lot in return. And so the Cancer Center has given a lot. We have our nurses, 45 of our nurses have been redeployed from the outpatient setting, from the ambulatory setting, to the inpatient setting. That's how good they are. And some of them went right into the ICU. I mean, absolutely amazing. They were in the ICU. They were ICU nurses maybe a year or two ago, and they went right back to the ICU. It's just been astounding at the talent level the cancer nurses have. And then on the physician side, I would say that we've had to stand up 3 new floors taking care of COVID patients. And being on the floor has been a remarkable experience. In some instances, we've had to go back and be both the intern and the attending, the intern, the resident, and the attending. And I served on one of those floors and had to familiarize myself with how to replete somebody's potassium and magnesium on the inpatient. But gosh, it was great. It brought back a lot of memories, kind of like watching the Michael Jordan series on TV. It's just bringing back all these memories from when I was a kid. So I have to say, I couldn't be prouder of the nurses and doctors in the Cancer Center for stepping up and contributing to caring for our community of sick patients. You know, the MGH always stands up to meet the challenge. It did 200 years ago, and it's still doing today. And the Cancer Center is a big part of that. So how has the Cancer Center changed? How are we taking care of patients? Well, I think I'm going to come back to this point at the end, but a lot of people are scared to work up their cancer. And so we have seen a drop in new patients, in part because we can't do screening. The governor isn't, the state of Massachusetts isn't allowing us to stand up the screening. So mammography, mammograms are off, colonoscopies are off. All the screening tools that we use for cancer are off. And I think people are sitting on their symptoms. One of the things that Dr. Nicholson and Dr. Britton know full well, being primary care physicians, is that cancer symptoms often predate the diagnosis for 4 to 6 months. And so it's our fear that a lot of people are sitting on some symptoms that they probably shouldn't be. And I think we, as O'Neill said, the work of cancer and the work of the Mass General is going on, and it's very safe. And we've been able to take care of people. In fact, our infusion unit volume is about 70% of what our normal infusion unit volume is. And in fact, the other thing that's happened is almost, I'd say, 2/3 of the visits that are going on now are virtual visits. We're all becoming incredibly familiar with Zoom and seeing our patients on Zoom. And that has been one of the great revelations, I think, and Zach alluded to this earlier, the virtual visits have just been phenomenal, and patients have appreciated it tremendously. The other thing that's happened is that the MGH Cancer Center is a very diverse and broad community. So not only do we take care of people in Boston, but we run the cancer services at the North Shore Medical Center in Danvers. We run the cancer services at Newton Wellesley Hospital. We run them out at MG Waltham. We run them up in New Hampshire in Exeter Hospital in Exeter, New Hampshire. We run them at Wentworth Douglas Hospital in Dover, New Hampshire. We run them in Nashua, New Hampshire at the Southern New Hampshire Medical Center. And we run them in Concord, Massachusetts, up Route 2 at Emerson Hospital. We run them all the way out at Cooley Dickinson Hospital in the western part of the state. And we also run the cancer services at Martha's Vineyard in Nantucket. So one of the great things that's happened is that when we see people virtually, they say, hey, Dave, can I get my scans at Waltham? Can I get them at Newton Wellesley? Can I get them up in Exeter? Can I get them down at Martha's Vineyard? Oh, sure you can. I guess so. And so we've created this centralized process that allows you to get whatever you need to take care of your cancer closer to home. Those systems, well, they kind of existed, but they were in a simplified form. And Mara Bloom and Beth Souza, our 2 lead administrators, and Erica Rosado, who runs our ambulatory nursing, have just done a remarkable job of making not only the care virtual, but making the care closer to you wherever you're living in your community. Of course, people do need to come down for their bone marrow transplant, which is going like gangbusters, and CAR T therapies and the like. And people do need to get admitted. And we are still running our cancer floors at the Mass General. So cancer care has changed, but it's changing for the better. And I think the other thing I'm very proud of is the clinical research that we helped stand up. So Keith Flaherty, who's our director of clinical research, contributed to the COVID crisis by running a scientific review committee, the same way we run scientific review committees for cancer clinical research, for all of the COVID research in the hospital. And one of the things that has become clear to us is not only is care going to be virtual, but clinical research is going to be virtual too. Just like we can sign consents now over Zoom, we can consent cancer clinical trials over Zoom as well. And we're going to be getting that clinical research out into the community. So what's here to stay? How has cancer care changed going forward and for the better? Well, virtual care is definitely here to stay. I think that everybody who is on follow-up, whether it's breast cancer follow-up, lung cancer follow-up, GI cancer follow-up, and you're getting your labs checked every 3 months or 6 months, and maybe you're getting a scan once a year, there's no reason to have to come in and see the doctor or the nurse practitioner to go over those scans. You can do that just as well over Zoom. In fact, I can share my laptop, my screen with you, and we can go over the films and look at them together. I think that is a change, and that's a change for the better. I also think that the distributed nature of care at the Mass General community at large, at all of our satellite sites that I mentioned, that's only going to accelerate. And is a change for the better, because I think people are really coming together to take care of everybody throughout the entire network. And then the last piece I would say that cancer care has changed is, just like we're getting together on a Zoomcast today, every single one of our disease centers, thoracic, hematologic malignancy, breast cancer, GI, all the disease centers, whichever one you're in, they're all coming together for several conferences a week to go over all the patients in the entire network of the Mass General throughout, whether it's Southern New Hampshire, whether it's Western Massachusetts, whether it's in the close-in satellites. Everybody is getting the same expert care throughout the entire MGH community. And we're all going over each other's scans. And I was just on a GI cancer case series today. You gosh, 20 surgeons, 20 medical oncologists, and the full radiation oncology complement, all commenting on the same cases. It's really a wonderful, comforting thing to know that when you come to the Mass General, you're not just getting my collective wisdom, you're getting the collective wisdom of all the experts at Mass General. And then I'd say the last point I'd like to leave you with is, if you are sitting on symptoms, don't sit on them anymore. Definitely give your doctor a call, give your primary care doctor a call, give your main physician or nurse practitioner a call and come on in. We are a little bit worried. You know, the cancer incidence each year is not being affected by COVID. It keeps going on year after year. The earlier we can detect your cancer, the earlier we can treat your cancer, the better off you're going to do. So it is my pleasure now to turn it over to Debbie Burke, who is the best chief nurse in the best hospital with the best nurses on the planet. So Debbie, thank you.
Thank you, Dave, and all of my colleagues who are saying such nice things about nursing. You always do, but it's because, in particular, because it's Nurses Week. So thank you. So as all of you know, nurses really spend the most time in direct care of patients. And this pandemic has not changed that at all. In fact, now nurses are spending even more time with patients because, as you know, patients with COVID-19 are not allowed to have visitors except under really dire circumstances like end of life. And the nurse-patient relationship at Mass General has always really been at the center of nursing practice. And so now that presence is more important than ever. But that also means that nurses put themselves at greater risk because there's a lot of exposure to patients with COVID. So our nurses have been incredibly creative in designing safer ways to care for patients, how to maintain that human connection, but also not have to go inside the patient rooms as much as they probably needed to before. And I thought I'd share a couple of examples. So they're using extra long IV tubing that allows them to manage IV pumps from outside of the room versus entering the room. Now when a medication dose needs to be adjusted or the alarm goes off on an IV pump, the nurse doesn't have to go into the room and they can adjust it in the hallway. This reduces their exposure time, and it also reduces the need for them to keep putting on PPE. You've heard of that, personal protective equipment. And as you all know, this is something that we still need to preserve. Nurses also are using iPads on poles in the patient's rooms, and Zach spoke about this, which is the iPad is in the room and the nurse uses an iPhone as a way to communicate with patients. Again, not having to enter the room. But they're also using this technology to increase the connection with families who have to be at home. This global pandemic has forced us to look at new ways of caring for patients. We traditionally had 133 intensive care unit beds at Mass General. And at the height of the crisis, we actually increased our beds to 229 ICU beds, which is nearly doubling the number of ICU beds. So we had to change how we cared for patients. We actually took 2 of our general care units, Dave spoke about this, 2 of our general care units in London, as well as one of our recovery rooms, and made them all into ICUs. So we needed to look at how could we expand our capabilities as nurses. And so what I would say, we increased the skill level of our nurses, but we also created this amazing partnership where we had an ICU nurse who's responsible for the oversight of care, and general care nurses providing a lot of the hands-on care for patients. We actually redeployed over 700 nurses throughout Mass General to really step up to meet the high end of this crisis. Those nurses came from our outpatient practices. They were research nurses. We even took some of our advanced practice nurses, like nurse practitioners, and brought them back to the bedside to provide hands-on care. But then what we also did was we thought, well, we need to help support those nurses at the bedside who are new to ICUs. So we created an ICU nursing support team. We actually brought back some expert nurses from retirement to be that 24/7 team so that they could provide at the elbow support of our nurses at any time. Another thing we've done is we've changed some of our nursing practice. Some of you have heard about this thing called proning. Proning is when we put patients on their stomachs, and it's been found to improve their lung capacity. So what we did was we created proning teams to help us to prone patients. The team consists of 6 people. Those 6 people may be composed of an operating room nurse or an OR tech, because of course they're really skilled at moving anesthetized patients. We included physical therapy because of course they're experts at body mechanics. And this group of 6 people actually move all of our patients. We believe it's safer for patients because they're experts at this, but it's also safer for us staff in trying to move some of these patients completely onto their stomachs. But we're also studying the impact of this intervention because we need to think about whether this is something we should continue moving forward. What we've also detected is that in having these patients on their stomachs for long periods of time, some of these patients are on their stomachs for 18 hours a day, that they're starting to develop pressure ulcers in areas that are very new for us. So pressure ulcers on people's cheeks and noses and ears. And so we're really studying ways to prevent pressure ulcers, but also effective treatments. And I want to talk a little bit about some of the innovation that's happened in care delivery. So, we had a lot of great ideas that we have been thinking about putting in place for a long time. But boy, did this crisis move some of these things forward much faster. For example, what happens when a COVID patient cardiac arrests? Doing CPR means you're in contact with the patient for a long period of time. And after your one provider doing CPR, you might bring another provider in because you get tired. So there's a lot of people that are participating in that care and having a lot of very direct contact with patients. So we went out and quickly purchased something that we have been looking at for years, which is an automated chest compression device. And so we can actually provide hands-free CPR to our patients now. And then a couple of examples of nurse-driven innovation. One of our oncology nurses developed a tool called Grab-a-Lab. This nurse has patent pending on this tool and a process for managing lab specimens that keep those who handle the lab specimens safe from exposure. It's been an idea prior to COVID-19, but now we got funding for 50 prototypes, and we're trialing those in a number of different areas right now. Another MGH nurse invented a safe blood drawing device for our pediatric patients that prevents staff exposure when drawing blood. And we're also looking at a number of innovations that from outside of Mass General, but we're trialing them here. For example, how do you keep a mask on a baby or a toddler? Well, maybe you embed a pacifier in the mask. What about a mask that has a pocket for a removable and disposable filter? These are some of the things that we're trying at Mass General. We're now thinking through about how to advance these ideas and also encourage staff to continue to come up with better ways to care for patients and also make care safer for them. So all of my colleagues have talked about what lies ahead. I have to say that I feel like there's a lot of unanswered questions at this point, both about the virus, but also how this is going to change our practice. But if you've been to Mass General, you'll see one thing for sure, and that is we all wear masks now. Because we're assuming that anyone could have the virus because we know that some people have no symptoms. That could be us or that could be you. So we're going to continue to wear masks, but we also recently asked all of our patients to wear masks, and it's unclear how long we're going to require that. This pandemic will change practice, but I'm not sure we all know all the ways that it will. But I think back to when I was a new nurse taking care of patients with the HIV virus, and we really didn't know how things were going to change back then. But we certainly manage exposure to blood and body fluids very differently now than we did back then. So I would say that care will never be the same, but some of those changes will be for the good. And lastly, I just want to share with you that I think that although it's been very challenging times, our staff have been doing a great job. Last week, I did night rounds with Dr. Peter Slavin, Dr. Tim Ferris, and our board chair, Jonathan Kraft. And I would say that we found it was a very different place than a few weeks ago. Staff are more assured, calmer, and more confident in their practice. They're providing expert care, and we're showing some great patient outcomes. And I thought I would close with a quote about the nursing care from one of our physicians, Dr. Joe Betancourt, who emailed me after taking care of a patient who he found was quite ill. He said, "I just can't say enough about our nurses. They are beyond heroes." He had just brought a Spanish-speaking patient to one of our ICUs who was very short of breath. He said the nurses there just jumped all over it. It was like a NASCAR pit shop with compassion. 3 nurses were on him doing everything, and I mean everything, from changing him to putting EKG leads on him, all as he was in respiratory distress, but all with compassion, encouragement, and expediency. Whether it's on the floors or the units or the outpatient side, Mass General nurses are beyond amazing. I can't say this enough or loud enough. Thank you. So I'm going to hand this over to Dr. Britt Nicholson.
Thanks very much to all of the panelists, and we're going to jump right into the questions right now. And I think this first question I'm going to direct to you, O'Neill. And it's probably a question that most of the audience has on its mind. This person says, I have a family member who is nervous to return to the hospital for routine care following the pandemic. Could you and the rest of the team talk about some of the precautions the hospital is taking to make sure that patients will be safe?
Absolutely. So first thing, you shouldn't be nervous because we come to the hospital every day and we're not nervous. And so we've seen a lot more COVID patients than you'll probably ever see. So that's the first thing. The second thing is that we have an excellent infection control team, really amazing people here. And they have studied the virus. They know how it behaves. They know sort of what we need to do to protect ourselves, and better yet, what we need to do to protect our patients. So as Debbie mentioned in her words, we have a universal mask policy, which is the first and probably most important steps we have taken, where we mask all our patients who come through the door, and we mask everyone who's working here. That allows us to do what we called, or what the infection control people call, source control. And so you assume everyone is positive until you're comfortable that the community spread has stopped. And so by doing so, we provide source control, and you cannot enter the MGH without having a mask on. The other thing that we have done is besides social distancing in the hospital and sort of reconfiguring ourselves to make sure that we're sitting apart and have space to move and do whatever we need to do, we have also really doubled and tripled down on the hand hygiene process, because beyond the mask, the most important things you could do is to keep your hands clean. And that, we actually do not necessarily encourage, we don't encourage anyone wearing gloves walking around the hospital, because we think that puts in this false sense of safety. And then people touch everything and then touch their face or something else. And so, you may lead to a self-inoculation. So we use our hands. We remember when we use our hands that anything we touch, the next thing is hand hygiene. And we have put a lot of Purell and hand washing facilities available to everyone who's in the hospital. So feel very assured. We are confident by doing these things, you'll be safe and you'll be okay.
Great. So Debbie, this is I'm going to combine a couple of questions here for you. It says, as chief nurse during Nurses Week, what would you like the community to know about the nurses at MGH? What inspires you and nurses every day to continue this fight? And how do you think this has changed the perspective and landscape of nurses globally? And then finally, given the fact that the visitor policy at hospitals has been such that family members can't attend, can you speak to the stress and the workload that this has placed upon nurses and how they are emotionally handling it?
Yeah. So I'm going to answer your last question first, because then I'll remember, and then you might have to remind me of the beginning ones. But
okay.
It does put a lot of stress on nurses, especially because even at end of life, when we do allow visitors to come into the hospital, family members, sometimes they're scared to come in themselves anyway. And so sometimes they don't. And so, but we use a lot of technology to connect patients with their families, but it does take a toll on nurses because they're providing a lot of the emotional support. But we also have colleagues who help us. We have chaplains, we have social workers, and we have each other, whether that's physicians and other nurses. But it is exhausting and it is taking a toll, but it's also what we do. And I would say it brings me into your beginning questions, Britt, which is, it's been a very strange way to celebrate Nurses Week. We usually celebrate very large at Mass General, and we've had to be a lot more subtle in how we've been celebrating, but we've also moved our entire celebration. We hope we're going to be able to do it all in September. The way I celebrate the nurses these days is I try to round every day and check in on them. And we've gotten wonderful donations from a lot of restaurants and companies. And so I've been able to bring lunch to them. We've gotten donations we actually even got donations of shoes. And so it's been a lot of fun, but it's also a way for me to connect with them. And finally, I would say that I have never been more proud to be a nurse or to be an MGH nurse. And I would say that that is the sentiment that I feel around the hospital. And it doesn't mean that nurses aren't afraid sometimes. They worry about themselves, they worry about their families. And I just think that's natural, but I think we've gotten into a different space now because of how much we've learned about this virus. And as O'Neill said at the very beginning, we watch very closely how our staff are feeling. We test them if they have symptoms, and our incidence of staff with COVID is low. And so we feel good about that. I think I answered all the questions, Britt.
Well, maybe the very first one was, as chief nurse during Nurses Week, what would you like the community to know about the nurses at MGH?
Yeah. That we're happy to be here at Mass General, ready to take care of them. And because this is what we do, and we have the skill and expertise to do it well. And as all my colleagues said, please don't stay away from Mass General, because we're here and we're ready to take care of you.
So David, since a number of your patients are older, you might well have been sort of asked this question. What are your thoughts about visiting grandkids if they live out of state and you will be staying in their home?
No, don't do it. Yeah, we've learned is that kids don't get as sick. You can get sick, and of course there's been this Kawasaki-like illness that has been in the news, but by and large, most kids don't get sick with this, but they are carriers. And so particularly for our cancer patients and for folks over 70, you really have to be aware of that, unfortunately. We have, my wife's parents live down in New Bedford, and they have a nice big back porch. And so we go down and they sit on one side of the porch and we sit on the other side. And that's pretty much as close as I think that people should be getting at this particular time. And, you know, we have been worried about specific populations getting this. And in addition to the elderly, we are concerned about cancer patients getting this. On the other hand, one of the real thankful things we've seen in the cancer center is we haven't seen a lot of our active cancer patients getting COVID. So people are coming into the infusion unit, getting their chemotherapy, and thankfully, knock on wood, we haven't seen a lot of severe disease in cancer patients over and above what we would see in the regular population.
So Zach, you mentioned that there are a number of anti-inflammatory drugs that you normally use with your rheumatologic patients. Are there any particular drugs that look promising that are undergoing trials here at the MGH?
Yeah, I think that's a great question. There definitely are several that have looked promising. I think the most recent data that's come out around one of the trials looking at an agent that blocks what's called IL-6, which is we all have IL-6 in our blood, and it causes our immune system to do certain things. And in some diseases like COVID, it could be very high and reflect a very high inflammatory state. So we're involved in actually at least 2 clinical trials looking at 2 different drugs that help lower the levels of IL-6 in the blood, or at least block the effects of IL-6. And so we're really optimistic about this drug, and we're excited to see some of the results. And it's been really amazing, you know, as Dr. Ryan mentioned, to see the clinical trials that have been set up so quickly and the enrollment going on so fast. So we're hopeful that these will give us some assuring, promising answers soon.
Okay. So O'Neill, one of the things that's really changed is since the beginning of this pandemic are recommendations around the use of masks. You know, starting out when masks are not really necessary to everybody needs to wear one. This question is, can you please speak about the different types of masks available for the general public and the level of protection that each one provides, and which one should we use to go on when we visit the MGH for an appointment?
So let me start with the last part of the question first. If you do come to the Mass General, you'll be given a surgical mask, what we call a surgical mask, which is what most of us have been wearing. It's this mask that I could put on right here in my office, and we'll be given a mask, and you'll walk around with the mask until you depart the property. So the mask question is largely dependent on, you know, whether you need to wear a mask outside the Mass General, sort of in the community, is largely dependent on what we call community spread and our sense of community spread. And so in the earlier parts of the pandemic, when our number of cases weren't as high as they are today, we did not think the general public needed to mask up. Now, this is in the context, though, of a larger mask shortage. And so, you know, I think if we had all the resources in the world, and which would include all the masks we wanted, then we would have probably told people to mask up a little earlier than we did. But quite frankly, with a low level community presence, the benefit of mask is sort of diminished. Now, as the number of people who were tested proved to be positive, I think it became more apparent that having face covering would be beneficial. And the face covering, again, is not necessarily to prevent the disease from you from getting the disease. It's actually to prevent the carrier from spreading the disease. That's the major purpose of it. These masks are not airtight masks, so they won't prevent you from breathing. But if somebody is, as David mentioned, is asymptomatic, walking around like one of these grandchildren that was mentioned, their ability when they cough or when they sneeze will be trapped even by a handkerchief or some face covering that may be present. And so the viral load that would normally enter the air is diminished, and that alone may allow you or make it less likely for you to contract COVID-19. I'd finish up by saying that in the hospital we have different degrees of mask. The most protective mask, and again, when we're in patients' rooms with known COVID positivity, the best equipment is not only mask, it's sort of a gown to cover the entire clothing, it's an airtight N95 mask, it's a face shield, and it's gloves and hand hygiene. Those are the sort of 5 tenets of how we prevent COVID. I think asking people to do that on the outside would not be necessary. And even people wearing N95s in the outside, if they were walking around, these are specialized masks that has to be fitted to the contour of your face. So if you went to Home Depot or you had some from Target before the shortage kicked in, it won't necessarily fit you as the way we test it. But any covering is better than no covering at this point. And with the community presence, everybody being covered is probably the most important. And again, hand hygiene and symptom monitoring. If you don't feel well, stay away from people and sort of self-quarantine.
Okay. So Debbie, what are the current recommendations for the testing of staff?
Yes. Right now, so I should say there's 2 things that we do. O'Neill talked about how all of employees wear a mask at work, but the other thing we do every morning or every evening before you come into Mass General is we get what's called a COVID pass, and where you go online and there's a list of symptoms that are there, and it asks you if you have any of these symptoms, and then the final question, the final answer would be, I have no symptoms. You click that, you put your initials in, and then you get something that on your phone, your iPhone, or so that when you come into work every day, you have your Mass General ID, and you also show your COVID pass that says you have no symptoms. Now, if you had symptoms, that would be when you should be tested. And some of those symptoms, as everyone knows, are things like fever, sore throat. Some of those are the kind of symptoms that we're looking for. But because there's a lot of people that think that they would just like to be tested, but we don't have enough testing to test everyone. So we really abide by those symptoms. You have to have some of that. Some of that might be a dry cough. Some of that is, you've probably heard about lack of taste, allergy symptoms that aren't really related to allergy. Those are some of the symptoms that we're looking for, not only in the general public, but all of our employees. And then if they have those, then they may be recommended for testing.
Okay. Zach, you have a number of patients that are on medications that suppress or affect their immune system. Are you giving them any different or special instructions in terms of how they should conduct themselves?
Yeah, it's a really important question. Our patients aren't getting any different instructions than everyone else right now in the area. So we're really counseling everyone to kind of try and stay at home if they can, distance themselves from others, avoid visiting people who are sick or have symptoms, and really emphasizing the importance of sort of hand washing and really just being careful. And I think that's really been very effective in helping keep our population of patients safe in the context of this disease.
Okay. So O'Neill, I imagine the number of deferred surgeries and procedures is tremendous. Do you know how many are there, and do you expect to be able to rebook all of them this year?
So I can't give you a number, but I can tell you it's in the hundreds and high hundreds at a minimum. And so we have looked at all our cases that were previously scheduled. We have stratified them in terms of most urgent to least urgent. And we have begun the process of starting to reopen our ORs and taking on the cases that we think need to be dealt with in the very near future. So, we're going to work down the list. We're confident that, if the trends continue as they are, that we'll be able to get to everyone. But again, the big variable here is what's happening outside our walls. What's happening outside the community. If once nationally and locally, if we reopen too quickly and there's a second surge, how do we manage that? I mentioned earlier that we had 83 COVID patients in our ICUs. Our ICUs, actually, the volume of patients in our ICUs is larger than our historical number. It's actually 30 more than our licensed ICU capacity, which is 130. So this morning we had 163 ICU patients. And as we go through our caseloads, we're going to choose patients selectively, patients who may need the ICU or not. And as those numbers trend down, and as I may have mentioned earlier, we have about 11 less COVID patients every day. That's the average that we're going down. So at about 193 patients, if trends continue, maybe we'll get to a bottom in about 20 or 30 days. But we expect some capacity to open up and we'll get back to doing what we always did. So we're pretty confident, but the variables that are out of our control include what goes on in the community, whether there's an outbreak elsewhere, whether there's an outbreak in a neighboring state that becomes pretty hot, that then overflows into the Massachusetts space. So we're watching all these things. So I'd say that overall, we have a plan in place, and it looks like a great plan to get our patients the care they need.
David, during your comments, you mentioned Dr. Keith Flaherty and the fact that he was overseeing the scientific review committee. Can you talk about how both clinical and basic research has been affected by this COVID crisis?
Oh, it's been hugely affected. So a lot of the labs have been shut down. In fact, most of the labs have been shut down. And much of the clinical research, for instance, in the Cancer Center, has slowed down. We have clinical research going on in the Cancer Center, but only that clinical research that we think affects materially somebody's survival. So if you have cancer and you have, say, a specific mutation, and the only thing that can stop that cancer with that specific mutation is a targeted drug, and we have that clinical trial, well, that trial's remaining open and accruing and doing okay. But one of the things that's happened is that the pharmaceutical industry has also had to send everybody home. And the pharmaceutical industry also, a lot of these clinical trials require sample collection. They require blood tests to measure the drug level. They require tissue biopsies to measure whether that drug is doing what it's supposed to be doing in the cancer cell, or in the case of COVID, in COVID. So those things have to be collected and processed in a lab. The lab shut down. A lot of the science can't go on. A lot of the companies say, don't enroll our patients to a clinical trial if you can't do these other kinds of studies. The one exception, I would say, are the life-saving clinical trials. Those are going on, and we have to keep those going. And then the second are the COVID research that's going on. We're not going to figure out how to treat COVID without getting tissue samples and blood samples in addition to giving those drugs. So that research is still going on. And we just found out this week that that Harry Orff, who's our vice president of research at the hospital, has just started the first phase of opening up the labs at Mass General and its affiliated laboratories. And you're seeing that start to happen at other universities as well. So it really has slowed down the progress of cancer clinical research and other clinical research while we've devoted everything to taking care of COVID patients, but also devoted everything in the research community as much as we possibly can to standing up the COVID research. And Mass General has been front and center with this.
Okay. So O'Neill, I'm going to give you the last question and then ask you to close the program. And it's not an easy question. It's two parts. One is that I read that even though we are in the middle of a pandemic, some healthcare providers, nurses and doctors in particular, are losing their jobs. Is this happening at MGH? And can you speak to the rephasing of our economy?
So two hard questions, but worthy questions indeed. So, healthcare traditionally has been a low margin business. It's a business where, we sort of see it more as a mission rather than a business. And quite frankly, across partners, our goal, for instance, is to make 2.5% more money than it costs to run the entire partner system. So with those thin margins, having a decrease or a downturn such of this magnitude definitely has negative impacts. And it has negative impacts across the industry. So our volume or our revenues are down an average of about 50%. And so we are very fortunate at MGH and across Mass General Brigham because we had been saving a while for in case there was a rainy day. And as some of my colleagues says, it's raining. So we have been fortunate in reassuring all our employees that we will not, we were able to keep everyone employed, not only doctors and nurses, but the people who clean the rooms, the people who valet the cars. We've been able to keep everyone employed. And we have promised to do so through June. But we are facing significant challenges. At the MGH alone, we're down about an average of $5 to $6 million a day. And so that adds up over time. And so our ability to tolerate this seismic disturbance in our environment is somewhat limited, but that time isn't here yet. And I have to praise Ann Klebansky, the CEO of Mass General Brigham, Peter Slavin, who led this charge, and all the other leaders around the Partners Health System who came together and decided that we will try to make all our workers who are trying to execute on this heroic work stay whole. And we have been able to do that, and I think our employees who are like family feel very appreciative of that. Other healthcare systems have had less to work with, and so they had to make tough choices. Over at BMC, they had to furlough about 1,000 people. At Atrius, they had to withhold 25% off the clinician salaries. At the BI, they had to hold all bonuses and all sort of clinical bonuses that people had earned, but with an idea of sort of looking at that as deferred income. So we are fortunate. We saved, we were able to use our rainy day fund. We're hoping that as the pandemic subsides, we'll be able to start back up and sort of get back on our feet and hopefully rebuild those rainy day funds. Now, as it pertains to the larger economy, the big challenge here is, the timing of reopening, and it's not an exact science. There's tremendous economic pressures, as you are all aware, as people try to figure out, how best to get back and get the economy going again. But if we do it too early, we'll definitely overexpose people. And if we do it too late, the financial ruin will be significant too. We understand both sides of the coin. I think we've been advising the governor to sort of watch the numbers and listen to the numbers, and he has been dutifully doing so. And we are with him arm in arm in trying to figure out what the next best steps are. So overall, I'd say we're not there yet. We still had 170 people die yesterday. We still have 70 to 80,000 people infected. We need to see those trends continue to go down. I think we're looking for probably the next 2 to 3 weeks. And I sort of agree with the governor that maybe we'll start experimenting with some small, low-level reopenings. Watch the numbers. Usually after you make a policy move, you don't see the results of it until 3 weeks after. So these policy moves will have to be slow, gentle, and then we have to watch the numbers over the next 3 weeks to see the impact. So, I'm hopeful that, by, July or so, we'll be much more aware of the numbers and where we're headed and be able to take more chances. And then overall, I'd just like to, first of all, thank the panelists who took the time to speak with us tonight. I'd like to thank all you participants who have supported the MGH over the years and who asked these great questions. I think these are wonderful questions. I'd like to thank the entire MGH community. I mean, if you are at the MGH, you recognize the magic in the place, and the magic in the place are the people. And many of us on the panel have described the people here. We have come together as a team. It has been unbelievable sacrifice by many. There are many heroes here who you'll never know their names, but they're heroes nonetheless. And I think everybody has acted in concert to not only treat the patients in front of us, but to be a real important piece of the larger population puzzle across the city and across the state. And so I'd just like to really take a moment to thank all these folks who have done this yeoman's work and has met the challenge of this lifetime pandemic with unbelievable effort and really remarkable resiliency and excellence. And so thank you all, and I hope you stay safe and stay healthy. And if you need any help, or if you don't feel healthy, feel free to call us. That's why we're here.